Good afternoon. I'd like to thank the chairmen of the session for inviting me to speak and the other organizers for this meeting. It's always a pleasure to return back here to Barcelona. So my session will be a little bit different because this cancer is extremely rare and there's not been dramatic developments over the past year. So I'm going to really focus on some of the new trials that are ongoing and what's the rationale for them. So these are my disclosures, and this also includes some of my commitments in regards to colorectal carcinoma. Touching upon the incidence, prior treatment guidelines, new immunotherapeutic developments, changes in treatment guidelines, and ongoing clinical trials. And once again, like the other speakers, I'd like to thank those that have stayed this late. I know it's towards the end of the meeting, so we're very appreciative. The incidence of anal carcinoma, just in general, has been rising by about 2.2% per year. And finally, this year in the United States, it has stabilized. But globally, it will impact about 35,000 individuals. And just keep in mind that the majority of patients will present with early stage disease. They'll be treated with chemoradiation therapy with curative intent. But risk factors for residual or recurrent disease still remain, which is largely bulky adenopathy as well as a bulky tumor greater than 4 centimeters. Metastatic disease will occur in about less than 20% of patients, and for the purpose of this talk, most of the developments have been occurring in the stage 4 setting. As you know, the standard of care remains for early stage disease with chemoradiation therapy. For the metastatic patients, the 5-year survival is expected to be about 32%. And these were the original guidelines, basically stating that 5-FU-cisplatin is recommended, but no other regimens up until that time were found to be effective. We now have a couple other regimens that have been since published or presented. So prior to 2018, basically you can see here many small studies, retrospective analysis. At MD Anderson, we had one of 77 patients looking at carboplatin Taxol, 5-FU-cisplatin. And then finally in 2018, Dr. Kim from the French group did a prospective single-arm study of docetaxel, cisplatin, and 5-FU with a response rate of 89%, a PFS of 11 months, and the median overall survival had not yet been reached. At last year's ESMO, we finally were able to present our data of the first randomized phase 2 study looking at the most common chemotherapy regimens provided to patients, and this was initiated with the International Rare Cancers Initiative led by Sheila Rao at the Royal Marsden. And the International Rare Cancers Initiative was a group founded basically to support a rare cancer and to try to establish a new standard of care. And our original objective was to establish feasibility to create this group and to focus on the metastatic setting because there really was no standard treatment. This trial enrolled, the intent was up to 90 patients. The primary endpoint was response rate, and if the response rate was equivalent, the intent was then to focus on the treatment arm with the least toxicities. And as you can see here, this is 5-FU-cis on a Q28-day schedule, and then carboplatin and weekly Taxol on a modified Q28-day schedule as well. These were the results that were presented at ESMO. The response rate was equivalent in this treatment-naive patient population, 57 to 59%, as you can see here. The primary toxicities were notable in the 5-FU-cisplatin arm for diarrhea, fatigue, febrile neutropenia, and mucositis, and less toxicities, but noted for anemia and fatigue in the carboplatin and weekly Taxol arm. The PFS trended in favor for carboplatin and weekly Taxol, although not statistically significant, but the median OS was definitely in favor of the carboplatin and weekly Taxol arm of 20 months versus 12.3 months. This resulted in a change in the NCCN guidelines this year, which I'm proud to say, and that basically will serve as our new chemotherapy backbone for further development. 5-FU-cisplatin remains in the chemotherapy guidelines, but carboplatin and weekly Taxol as well. Now, what about the refractory setting for metastatic disease? In regards to immune checkpoint inhibition, there appears to be a promising role. This is a very nice paper, once again, just highlighting that basically chronic stromal inflammation results in mesenchymal infiltration and basically immune deviation. And we actually decided to focus on the metastatic setting once again and not to compete with the INTERACT trial. So this was a single-arm study looking at Nivolumab in the previously treated patient population. Very simple study run through the NCI ET-CTN network. Primary endpoint here was response rate. And very much like INTERACT, we also allowed HIV-positive patients. As long as their CD4 count was greater than 300, we also allowed patients with hepatitis if they were being followed by a hepatologist. And this was basically enrolled very quickly within less than 8 months, so it was clearly an unmet need. These were the patient demographics, as expected, basically middle-aged Caucasian women with a PS of 1. Median line of prior therapies was 2. Median line of number of cycles provided of treatment was 6. And these are the results. The primary endpoint was response. We noted a response rate of 24%. We actually still have a prolonged confirmed CR of greater than 2 years. Our PFS was 4.1 months, and a median OS was 11.5 months. Keeping in mind, this is once again the previously treated patient population. Tolerated extremely well, no grade 4 toxicities, just a little bit of anemia, rash, and hypothyroidism. We did conduct some baseline correlative work, but once again, I'm not going to really highlight much of this. It's very small numbers because we did not have the funding required to capture the specimens from all sites, but we did note some increased, obviously, CD8 and PD-L1 expression in those tumors at baseline in the responders versus non-responders. We did look at mutation burden, and once again, this is a part A of an ongoing study, and we did not note that there was any correlation with tumor mutation burden in regards to response. And this is very similar to what's been reported previously published. Now, as you all know, there's also another trial that was completed, a phase 1b study of pembrolizumab. This was specifically only in patients, however, that had PD-L1 positive tumors. They found 25 patients eligible, and they reported a response rate of 17%. They did not have any patients with a complete response. But as a result, this resulted in a change in NCCN guidelines. So this really serves as the premise for further development. So now I'm going to focus on the trials that are ongoing. There is currently EA2165 that is currently enrolling. This allows randomization of patients either prior to chemoradiation therapy or following chemoradiation therapy, and this is specifically for your high-risk patient population, those with bulky tumor and lymph node positive disease. So the standard of care would be basically to complete your chemoradiation therapy and then follow these patients with close observation. Here they are randomized to Nivolumab once a month for 6 treatments. This study has enrolled 73 patients out of the proposed 200, so about a third of the enrollment. The primary endpoint is 2-year disease-free survival. Secondary endpoints are fairly standard, and this is being led by Dr. Lakshmi Rajdev at Montefiore. We've proceeded on to expand upon the original Nivolumab trial with the support of the NCI, and now this has become a randomized phase 2 study, and this now is enrolling as well. We hope to enroll 100 patients total. This is for previously treated patients, and once again, requiring 1 prior line of therapy. We're still allowing HIV-positive patients, and the schedule has now changed to the once-a-month dosing for Nivolumab. Primary endpoint now is progression-free survival. So we hope to improve the progression-free survival by an additional 3 months. And we are now obtained funding through the NCI and with Bristol Myers in regards to having funding for both pre-treatment and on-treatment biopsies, as well as blood collection. So that is being supported and being led by my colleague, Dr. Ignacio Vistuba. Just so you are aware, the HIV Consortium is also conducting a similar study. They hope to enroll 84 patients. I don't have the full schema, it was not available, but basically they're looking at a Nivolumab Q2-week schedule and also with the addition of IPI. And they're starting out at a CD4 count greater than 200 and then looking at patients with a CD4 count less than 200. This trial is still ongoing. Now, we do have another trial that you should be aware of that we just enrolled our last patient. This is a pilot study of atezolizumab plus bevacizumab in previously treated patients again. This is part of a Genentech Rare Cancers Alliance through MD Anderson only. Basically, it's multiple cohorts of other rare cancers. We decided to focus on this because the promising data in renal cell carcinoma for this combination, primary endpoint is response rate, and we hope to report those results next year. Now, the French group, because of their promising results in the treatment-naive patient population, they are now adding atezolizumab as part of their clinical trial design. This is a 2-to-1 randomization for basically treatment-naive patients again. They're allowing a CD4 count, but they're requiring it to be greater than 400. And this is basically the control arm is DCF, and then the atezo is provided Q2 weeks. Primary endpoint here is 12-month progression-free survival, and they hope to enroll 99 patients. The Italian group has avelumab plus or minus cetuximab, same patient population. The investigational arm is the combination. Primary endpoint is response rate. This is a pilot study of 54 patients that is ongoing, and they're requiring a CD4 count greater than 300. So to follow up of the INTERACT trial, and because of the results from ESMO were finally reported, we have created now the second part of that trial. Unfortunately, we were unable to obtain funding for an international effort to rejuvenate the study as part of the INTERACT group. As part of the IRCI group, sorry. But we have received funding for the US sites, and IRCI has been very kind to allow us to proceed with this study. So this will be a 2-to-1 randomization, taking into account carboplatin and weekly Taxol as our standard control arm, with the addition of Nivolumab for a maximum of 6 doses, followed by maintenance Nivolumab. 2-to-1 randomization of approximately 205 patients. Primary endpoint here will also be now progression-free survival. This trial is currently being finalized and has been approved by the NCCN steering committee to proceed forward. There is a trial that I would like to highlight, which I think is interesting. It's for all HPV-associated malignancies, and this is being conducted at MD Anderson by my colleague Michael Frumovitz in OB/GYN. This is looking at a DNA plasma vaccine involving E6, E7, and HPV 16 and 18. This involves electroporation. And this is the trial design. This is currently ongoing. I've enrolled 1 patient prior to my departure from MD Anderson. This trial will continue. Thus far, it appears to be tolerated very well. I don't have any preliminary information otherwise, though. But this trial is currently ongoing as a single institution study, once again for all HPV-associated malignancies. I wanted to highlight that there is a trial that should be opened shortly, not focusing so much on immunotherapy, but really focusing on reducing the amount of radiation therapy provided to patients with early stage disease. And this will actually be led by Jennifer Dorth at Case Western, a radiation oncologist. And this is the study design. Remember, the original NIGRA trial only provided up to 30 gray to patients with curative intent. This specifically is for T1, T2 tumors, less than 4 centimeters, once again, node negative. It does allow HIV positive patients, and patients will be randomized in a 2-to-1 randomization to reduced de-intensified chemoradiation therapy or standard chemoradiation. This protocol has completed its final draft and hopefully should be open shortly. This will allow 5-FU and mitomycin C or capecitabine, and it's a single dose of mitomycin at 10 milligrams per meter squared. The primary endpoint is 2-year disease control rate of greater than 85%. One thing that I think that's important to highlight in regards to new new biologic markers that will be beneficial potentially in your evaluation of patients is looking at the role of HPV circulating tumor DNA. This is very nice data from the French group. This was actually presented at ASCO 2018, looking at the reduction of baseline to following chemoradiation therapy of your HPV circulating tumor DNA. And basically, the patients that had redevelopment or residual HPV circulating tumor DNA, those were the ones that ended up with metastatic disease. Once again, the French investigators, based upon their DCF trial also looked at the role in the metastatic setting of looking at residual HPV circulating tumor DNA, and once again they found that that also correlated in regards to progression-free survival. So I think you're going to be learning more about this. Prior to my leaving at MD Anderson, we were getting this CLIA certified at our institution, and it is part of the 2176 ECOG trial that's being developed currently. So in conclusion, Interact EA 2133 has now identified a new standard of care for treatment-naive metastatic patients of carboplatin weekly paclitaxel. We believe that single-agent immune checkpoint inhibition provides durable and prolonged responses with excellent tolerability. And as you can see here, finally, for someone like myself that has been basically trying to find options for these patients for so long, it is so wonderful to see that there are so many ongoing trials, and hopefully we will have several new developments as treatment options for these patients. Once again, these are the list of all the various trials, and they're going across not only in the US, but internationally. And once again, we always encourage clinical trial enrollment. We really think that's the only way to move forward with a rare cancer in regards to treatment options. And I'd just like to acknowledge several individuals, not only at my former institution at MD Anderson for all their support, but also Vanderbilt Ingram Cancer Center because of my new role there and their support of my work once again in this rare cancer. Thank you for your attention.